Welcome, and thank you for joining Axxess and our panel of experts to hear about tools and strategies needed to successfully transition to hope. We are delighted that you have joined us for today's discussion. I'm Rayanne Melton, Senior Director of Clinical Services for Professional Services at Axxess. This is the first in a series of 6 HOPE webinars that aims to provide you with all the information that you will need to implement HOPE on October 1st. Before we get started, let's take care of a few housekeeping items. During our time together, the webinar questions feature will be available. We won't have time to address your questions in real time, but our panelists will respond by email. Early next week, all registrants will receive a link to today's recording along with the slides and additional resources. So now it's my pleasure to welcome our panelists. First, Amy Rose. Amy is the Senior Product Director for Hospice and Palliative Care Solution Delivery at Axxess. Prior to joining Axxess, Amy gained extensive hospice and palliative care experience at the agency level, and Amy is a registered nurse. Also joining us is Karen Chamberlain, another Axxess team member who is a registered nurse with extensive hospice experience. Karen is a product manager for our hospice solution. Welcome to both of you. We're going to begin today with a brief overview of HOPE to level set our conversation with Amy and Karen. In looking at CMS's objectives with HOPE, there are 2 takeaways I'd like you to think about. First, CMS is looking to standardize data collection that informs the patient's plan of care across the healthcare continuum. And second, HOPE will inform future payment refinements, like what home health is experiencing currently with value-based purchasing. HOPE is part of the Hospice Quality Reporting Program, replacing HIS. The 4% penalty for submitting less than 90% of the HOPE records within the 30-day submission deadline is still in play. The good news is that CMS is giving us Q4 or October to December to get it right, and the collection period for the first compliance determination is January through December of 2026. HOPE data must be collected on all patients admitted to hospice, regardless of payer source, patient age, location of care, level of care or location of hospice services. This is a shift across the healthcare continuum that CMS is requiring data collection for that where we used to collect it just for Medicare and Medicaid beneficiaries. Now they want it collected for all patients. The 2026 Hospice Final Rule affirmed that hospice would begin on October 1st, 2025. Remember, patients admitted before October 1st will have a HIS admission and a HOPE discharge only. Data submission for hospice update visit is not required for any patient that was admitted before October 1st. HOPE impacts clinical, operation, and technical areas of our businesses. From a clinical perspective, there are new and changed data items, new data collection time points, and a new focus on the impact of symptoms on patients. From an operations point of view, there are new and changed data items, visit time point windows, and required symptom follow-up visit parameters that will affect staffing. Technically, the transition to iKeys for data submission requires that all hospices register in iKeys prior to October 1st. And here's a visual of the visit time point windows, should a patient be on a service for 30 days. And there's 2 important takeaways that I want you to consider here. Even though Hope admission window is described as day 1 through 5, CMS defines the date of election as day 0. As a hospice admission nurse, the expectation when I was doing admission was that the admission was generally completed on the day of election. If that is the case, you need to closely monitor that date of the first HUV1 visit. If you do it too early, you might unlikely have it occur in that admission window instead of in the HUV number 1 window. Next, as we know, discharge can occur at any time. If the patient is discharged in the first 30 days within an HUV window, the data submission for that HUV time point is not required. It would just be, for instance, if it was admission and the death occurred during the HUV number 1 window, it would just be admission and discharge that would be required. And if the death occurred during the HUV 2 window, it would be admission, HUV 1, and discharge. What do you do if your team misses an HUV or the HUV is late? Per CMS guidance, they want you to conduct the visit and submit the record as soon as possible. However, you will likely be out of compliance. If this becomes a consistent problem, your organization may be risk for a payment penalty. So these are what I thought were the highlights of the overview of Hope. This is going to conclude our presentation on the level set on Hope. And now we're going to move into our panel discussion. And please note, we're going to include the this presentation in the handout section of the of this, so you can download it. All right. So onward and upward. Axxess has taken a strategic approach and proactive approach to Hope preparation, recognizing its significance in shaping the future of care delivery. From launching comprehensive education initiatives that empower providers with knowledge they need, to designing innovative solutions that align with evolving regulatory requirements, Axxess is committed to ensuring a seamless transition. Amy, let's begin with you. Tell us a bit more about your role at Axxess and your experience in the hospice space.
Hi, Rayanne. Thank you so much. Thanks to all of the attendees for being here today. In preparation for Hope, we know, Hope is the biggest regulatory change that we've seen in the hospice industry in almost several decades. So it is really quite important to be prepared, and it's been really exciting and fun to bring solutions around this regulatory update to the Axxess solution. So like Rayanne said, my name is Amy Rose. I am a nurse by background. I have had a variety of experience in the hospice, home health, and palliative space, but at my core, I started as an inpatient hospice nurse, kind of moved up through also being an admissions nurse, Rayanne. So my purview of hospice care kind of spans the gamut. And then also, of course, from an operational perspective, I think it is just going to be so critically important, not only that we bring a delightful experience to the clinicians as they're trying to document against this new regulatory update while also caring for patients, but also that we bring a delightful operational experience, because there are these new additions of time points, new forms. The SFV requirement is slotted to be, quite the regulatory, management challenge. So we'll get into all of that today, but.
Great. Amy, when I arrived at Axxess, I had no idea what the product team did, no idea at all. I still am kind of in awe of all of you. Can you share with us a sort of an overview from the product perspective? Maybe you can explain to those of us who might be like me what product is and how you approach designing such a large regulatory update.
Absolutely, Rayanne. I think it is so important to think about the solutions that we interact with every day and how if you have, an experience navigating something that's frustrating or that introduces multiple clicks to get to the end result of what you want, or you're not understanding how to even get the end result of what you want, all of that really speaks to user design and also making sure that the product that you're using, it makes sense for the purpose that you're trying to achieve. And so when it comes to regulation updates as a nurse, I always get a little bit protective of the clinical experience because what I never want is, as a nurse, to have to sidestep my routine care delivery for my patient in order to suffice a regulatory need, right? At the end of the day, I'm really laser focused in caring for my patient. So how do we build product that is supportive of that, that brings the experience of regulatory change in front of the clinician rather than the clinician having to learn new behaviors or new side steps in order to meet the regulatory need or even just document the regulatory need. One of the biggest things when we started really looking at the HOPE updates way back over a year ago, the product team started to really deep dive into the CMS regulations as they were then. Thank goodness CMS hasn't made any real major changes since then. We were prepared for some pivots, but that never did come down the pike. Um, so when we started looking at, okay, what does his look like today? We captured data in the first 5 days of care. It's primarily just one visit that captures that data typically, as well as your intake process and that kind of a thing. The biggest change with HOPE is that now we have 3 data points within the first 30 days of care. So we've got the, first 5 days, 16 or 6 through 15, 16 through 30. But when you look at what is being asked for in those time periods, for the most part, as a hospice nurse, I felt and my colleagues felt like, okay, well, that's just routine, pretty good care. Of course, most all of my visits, I'm asking whether the patient is imminent, probably not asking out loud, but assessing whether the patient is imminently dying. And then also, I'm looking at their skin conditions. I am assessing their symptoms. I'm following up on those symptoms as necessary. Those are all of the HUV questions and really the new questions that were introduced at the admission time period as well. So when we started looking at all of those changes, uh, we, of course, started to identify how do we make this and design this in such a way that it's not disruptive to routine clinical flow. And so we've really built it with that in mind. And then, of course, the other thing that was important to us is, I've already kind of alluded to this, but as a clinician, we know that it is a high burden when regulation comes down the pike. It increases the time it takes for us to document and increases the questions that we maybe need to ask and answer to our patients. And so how do we look and see where we can also identify areas in the solution where we can reduce the amount of time they're already spending documenting so that they have a more streamlined experience and we can kind of have a give and take so that we're kind of alleviating some clinical burden while also having to introduce some of these new questions. And those were and then of course that resonates also operationally. Where can we introduce opportunities for the organization to be able to see across their patient population, see into areas of vulnerability, and then take action on those areas of vulnerability with this new regulatory change.
Great, great. And I just have to warn all of our attendees that when the three of us get together, it's kind of like the Hospice Geeks Association. We've all been doing hospice for so long. And one of the things that we talked about that I think you spoke to quite eloquently about, Amy, that I'd just like you to touch on is, how we are disappointed that they actually called this data collection visits instead of data collection. Can you do a little rip on that? Because, that was something that's really, it's been top of our mind. And it has, as I'm out on the speaking circuit, it is a lot of confusion for hospices that I speak with on the road.
Yeah, and I think so when you're looking at the hospice update visit window, is kind of what we like to call it internally. So CMS calls it the hospice visit, the hope update visit. However, it's a window of time. It's days 6 through 15 or 16 through 30. And you have at least one visit, but probably two if your symptoms have, you know, visits that are out of control. So you have a window of time. And I do think that CMS did us a little bit of a disservice calling it a visit because it gets to be confusing. So really the way that we see it at Axxess is that it's a window of time and we're capturing data across that window of time. Whatever clinical information is happening, it's not just one visit that's potentially informing what you're going to be sending to CMS on your Hope update visit form, but rather data from across potentially a variety of forms. But again, if you have a symptom follow-up visit that's due at least two forms or at least two assessments that you're making for your patient. So to me, they're not visits. They are simply, it's a period of time where you're abstracting clinical data and quality data from clinical documentation.
Thanks for that. Okay, Karen, tell us a little bit more about your role at Axxess and your experience in the hospice space.
Oh, you named it right off the bat. We're a bunch of geeks here that have been there for a very long time. But my name is Karen Chamberlain. I am a registered nurse. I have been blessed to work in the hospice space for almost 30 years now. And over that time, I filled many roles, starting my journey as an on-call nurse, and then eventually a case manager, and then, a clinical director, and then eventually a director of education and a billing manager. And each of these roles, I feel, has given me quite the unique perspective, all the way from the bedside to the back office. And I have since brought that experience to Axxess Hospice as a product manager.
And we are thrilled you are. I often refer to Karen as our unicorn because it's rare to find someone who knows everything from the intake to the billing side. So I am always thrilled. And when I have a question, I go to Karen for my answers. So Karen, share with us in what ways did that Axxess leaned into innovation when building the Hope integration?
Yeah, just to kind of expound on what Amy just said, when the hospice set was first introduced back in 2014, I helped to implement it. And for many years, I personally reviewed and submitted HIS records myself. I've been in the clinician. So that experience, has really given me a deep appreciation for the challenges clinicians face in balancing, those documentation requirements with patient care. I can still hear my fellow clinicians saying, "I just want to take care of the patient," right? And I'm sure I've said that myself. We've all said that. We just want to take care of the patient. And now with Hope, those requirements have significantly grown. There's more questions. There's additional time points that we need to collect data, such as those hospice update visits and those symptom follow-up visits. So we basically went from, an admission time point and a discharge time point to an admission, hospice update visit 1 and 2, plus potentially 3 other symptom follow-up visits for each of those initial time points. So, the documentation requirements, they've significantly increased. So our focus in building logic surrounding Hope was really to make it easier for clinicians to do what they do best, which is provide excellent care while still capturing the necessary data without really adding extra burden to the clinicians. So with that in mind, we designed the system so that as a nurse is out in their field and they're caring for a patient, they can just naturally answer Hope questions as part of their usual workflow. They're doing the work anyway, right? It's just part of their nurtural workflow. There's no specific form. It's just the forms that they would usually use to assess the patient. And then the system will then automatically do a sweep of all the documentation that occurs and those timeframes and extract any answers that are relevant to Hope and to the Hope form very seamlessly. So in other words, we brought quality change to the clinician rather than asking them to change their practice for the sake of documentation.
That's awesome. That's awesome. We've talked about how Hope data collection is capturing the care that hospices should be and are already providing daily. Let's lean into our approach that captures Hope data from admission to discharge to ensure compliance and drive improved patient outcomes. As I've already said, Hope will impact the hospice clinical, operational, and technical areas of hospice. Amy, let's start on that clinical side. What tools are going to be available clinically to support success with Hope?
Yeah, I'm going to kind of take one step further of what Karen was talking about. So we're just rolling on here. But, when that happens, when you bring the experience to the clinician of, them kind of just walking through their journey, they need to be guided in some ways, right? So that's where we kind of put in some forced hard stops, some required questions and fields at unique times during that journey, and also reminders, things that pop up at the end of visits that say, hey, you have a symptom follow-up visit due. Hey, don't move this visit. This is a symptom follow-up visit. So really putting some guardrails around there. And then Rayanne, you spoke to this at the beginning of the presentation, but really calculating the Hope timeframes. I mean, something just as simple as that. We have kind of collected all of that information into one area of the solution, where you can see per patient the timeline visualized. So the first 30 days of care, when does my HUV period start? When, do I have my symptom impact done? Do I have a symptom follow-up required? If one is required, has one been done? How does my CMS form look if you're a person that is processing those records to be sent off to CMS? So really marrying all of that, the visibility of that data. It's the command center, right? And it is clinically helpful because as a clinician, I can see my timeline and I can make sure that I'm caring for my patient while also caring for regulatory need. And again, I also have those pop-ups and reminders as I'm going in and actually caring for my patient. But then it's also hugely operationally supportive as well.
Awesome. Awesome. I began my hospice career as a dedicated admission nurse. And when HIS began in 2014, that admission HIS collection became part of my role. Amy, if you were speaking to me today in the role of that clinical nurse, what would you tell me is the single most delightful feature associated with Hope, the Hope updates?
So, building the experience of having a symptom impact that looks exactly the same as a symptom follow-up was really interesting from a technical perspective. And so one of the most delightful things that I think that we have done is really to automate for the clinician, whether if a symptom follow-up is due, it's an assessment within their visit that automatically kind of captures and populates. And so really leveraging automation and the delight of technology to make, again, that regulatory need just come up to the clinician when it is due, and prompts them to complete that assessment, I think is just hugely delightful as a clinician. Again, it's one of those things that when I was in the field used to drive me crazy because I'm also technical. And so as a nurse, I would say, I don't understand why this technology is making me take this extra step when I know the capability of the technology is to really make it easier. So I just find that hugely delightful.
As do I. As do I. Okay, so let's dive into that operational and technical impact of Hope. From ensuring accurate, timely completion of Hope data items to scheduling new required data collection time points, Hope is a paradigm shift on the ops side. Karen, would you share some of the tools available to support the operation and compliance side?
Yeah, absolutely. Amy started to allude to one of it, but one of the key tools that we built to support operational and compliance side of Hope is real-time validation. As a clinician completes their assessments, the system not only checks for missing or inaccurate responses to Hope items, but it also flags answers that might not align with, best practice. The kind of responses that might negatively affect performance under hospice quality reporting program. This gives clinicians immediate feedback right in a moment to give the best possible care and make the best possible documentation choices without having to go back and to correct it later. And since, Hope is part of HQRP, which is a pay for reporting program, that timeliness for record completion and submission is critical. Agencies are expected to complete admission records within 14 days of admission and Hope update visits in 14 days based off when the assessment was complete, and the discharge records within 7 days. So you can see how the completion of those records, it differs. And then they're expected to submit all the records within 30 days. And then without doing so, they risk that 4% reduction in reimbursement. So we've built in real-time tracking tools as well that show exactly how many days are left before a record needs to be completed and how many days are left before a record needs to be submitted, and provide that automatic visibility of the state of any assessments that are feeding into that Hope data. So with all those tools combined, and there are more, but we can ensure that teams can act, before deadlines are missed, and we're able to protect compliance, and we're able to avoid financial penalties.
And that's incredible because, I think that when we initially saw what Hope was requiring, it was like, how are we going to track all those visits?
Mm-hmm.
Right? How are we going to do it? So this is, I love this. So Karen, as you know, I'm also a recovering hospice clinical director and administrator. If you were speaking to me today in the role of clinical director or director of operations of a hospice, what would you tell me is the single most delightful feature associated with the Hope update?
If I were speaking to you today as a clinical director or director of hospice operations, the single most delightful feature of Hope updates would be the ability to see right in the patient's chart every Hope time point for that admission instance and if and when a symptom follow-up is due. When I attended the Axxess Growth, Innovation, and Leadership experience in May, which was phenomenal, by the way, I remember sitting in an incredibly informative Hope session and hearing the very real angst from organizations, from directors and leaders. They were worried about how they were going to manage all these essential time points, the hospice update visits, the symptom follow-up visits. And I can recall hearing someone say their organization was talking about, building a spreadsheet to keep track of it all. It really brought me back to my early days, when everything was tracked on paper. I don't know if you guys recall when we were tracking certifications and recertifications and making sure everything was timely. So with this feature, that stress disappears. And from the moment a patient is admitted, the system will automatically capture each time point. And at a quick glance, they can see exactly when that time point begins and ends. They can see if a symptom impact assessment has been completed and if a symptom follow-up visit is required and when it's due by. And this built-in guidance means no more wondering, am I missing that deadline, and allows agencies to really just focus on patient care.
Absolutely.
And Rayanne, if I can, I just had a couple of thoughts as you were speaking, Karen, on really highlighting, firstly, the acknowledgement that whoever in your organization is processing his records today, their workload is about to double in that first 30 days
Yeah.
of care. They are used to processing one record with a lot of data, mind you. So the admission record has a lot of data in it, but the HUV1 and HUV2 records has a lot of moving parts and pieces. So really, one of the things that we did first and foremost, right, was to really look at the way that experience of the individual who is processing records. How do we make this more streamlined experience? That was one area that we as a product team really felt passionately that we wanted to make some improvements, notwithstanding Hope, right? Like we wanted to bring some more streamlined experiences to that processing experience so that when we got to this moment where Hope is going live and these individuals now have that much more in their workload, that we've just already taken some of that burden from them in the sense of what it takes to process those records. That was one thought I had as you were speaking, Karen. And then the second thought I had was really the mindset shift of this is what happens when we go from thinking of things as visits to data in a time period, and the angst that organizations are feeling about what if I miss an HUV1, right? When organizations are asking me, what if I miss an HUV1? How am I going to see if whether or not I'm missing this um, time period? My challenge to that, and this is unique to our design at Axxess, but my challenge to that is, are you routinely not seeing your patients between days 6 and 15, right? If you're not seeing your patient between days 16 and 30, I'm really concerned because there's a regulatory concern there. But between days 6 and 15, there is a small window of time where you potentially aren't seeing a patient. But if the patient's not receiving a skilled nursing visit between those days, then yeah, you have the possibility of missing an HUV1 window, and you should be kind of assessing your clinical care and operations to ensure that if you're not already seeing your patients at least once a week for the first 4 weeks of care as a baseline bare minimum, that should probably be a best standard of practice. But the way that our approach is at Axxess, because the data comes to the clinician rather than the clinician having to schedule a unique visit, how are you going to miss an HUV1 or HUV2 period unless you're not seeing your patient between those days of care? So 1 week 4 with 3 PRNs is my bare minimum recommendation for that initial frequency.
That's great advice. And if I can just, since we've gone down this road, our very first webinar in March of this year was with Jennifer Kennedy from CHAP, and it is available to be viewed on our Hope landing page, which you're going to receive a link for. And one of the very first things that we were recommending in that webinar is that the first step in preparing for Hope is checking your current processes. To Amy and Karen's point, if you have broken processes with his submission, you're going to probably have them multiply tenfold with Hope. So understanding where that breakdown is now is important. And I always say, you've got your policies, you've got your procedures, and then you have your practices. And those practices are the workarounds that team members have developed to make the system work for your organization. And you really need to look into that to make sure and identify. Now, yes, we are starting Hope data collection on October 1st, but in that Q4 of this year, October through December, I think we have a little wiggle room to get it right. So really taking a look at those processes and looking where the gaps are. I was recently at a conference and I had a hospice administrator come up to me and ask me advice because they had just learned that due to a failure, 100% of their HIS documentation wasn't submitted for 1 month. And, ultimately, it's the provider's responsibility to ensure that the data is not only submitted, but accepted within those 30 days. So this is really a good time to look at where you're having problems. Are you having trouble staffing visits? If you're having trouble staffing visits, how are you going to staff those in person within 2 calendar days symptom follow-up visits? Karen, any thought about I see you shaking your head while I'm talking. Any thoughts around advice that you would give in regards to this preparation?
Yeah, coming, from a space of, in my former life, I was a director of education. So the number one recommendation is education, education, education. But agencies, they should be making sure the clinicians are well prepared, not just, with a basic overview, but with hands-on familiarity with the actual Hope questions and how those questions should be answered to support the best quality scores for HQRP. This isn't just about knowing what to answer, but understanding why each answer each question matters and how it ties directly to performance in the hospice quality reporting program. And the more confident that clinician feels before go live, the smoother that transition is going to be. And the agency is going to be better, positioned to succeed from day one.
How about you, Amy? Any thoughts? Any few other thoughts on this?
Yeah, I mean, I think that you really hit the nail on the head, Karen. And I think also, Rayanne, so it's the clinician understanding how their actual activity is informing practice, or not practice, but how it's informing what needs to come next, right? And I mostly think about symptom impact here, because as a clinician, if it is that Friday and I'm doing maybe an admission and I'm assessing that my patient has these symptoms that are impacting them, and my routine practice wouldn't necessarily be to schedule an on-call visit over the weekend or make sure that there is a weekend visit that's been made, that SFV is going to be missed, right? If that admission nurse doesn't understand the impact of her impact assessment, it's going to necessitate a visit over the weekend. And that extends beyond just admission, right? That's also case management, because if my HUV1 window of time starts maybe on a Friday and I just happen to have a Friday assessment, that really is going to necessitate that follow-up visit be over the weekend. So really an understanding of the questions and also the follow-up. And then the last piece there I have is really the importance of timely documentation. So your systems can only do so much with the data that it has, but if it doesn't have the data, it can't support you as an organization in making sure that you're compliant with specific things. So if your clinicians aren't documenting their symptom impact assessments timely, you as an organization are not going to know whether you're missing an SFV. So be sure that if you are in looking at your clinician behavior, and if your clinicians are documenting 2, 3, 4 days after care has been delivered, which we know that already degrades the potency, I guess, for lack of a better word, of the documentation. It's also going to potentially impact your ability to stay compliant if they're not understanding that, oh, I'm documenting this admission that happened 3 days ago, but patient symptoms were out of control, so I'm going to document the impact, but we also didn't schedule a follow-up visit within that 48 hours, and now it's 3 days later, so I'm past that window of opportunity.
Great point. And I know that all three of us, and I'm sure most people in the attendees who are in that leadership role as a team manager, as a clinical director, as a director of operations, or an executive director, struggle with staff not completing point of service documentation. And this has been, I've been beating this drum for, 20 years in hospice, and finally I got to a point with, don't talk to me about work-life balance, your poor work-life balance, if you're not doing your documentation when you're with your patients. If you decide to take it home with you, I can't help you build work-life balance. Mm-hmm. So, and I think that this is really going to, you as a leader, and speaking to our attendees, as leaders, if you really need to help your staff understand that your clinical staff understand. Unfortunately, this is a heavy RN burden. Mm-hmm. The only place we can insert an LPN is at the in the symptom follow-up visit. Mm-hmm. But the heavy RN impact. So, really, bringing, circling up with those RNs that are providing care and, bringing these points home are really going to be very important to your success with Hope. I'll get off my soapbox. I don't know. Does anybody want to jump onto it before we move on?
Oh, listen. Point of service documentation, listen, not only does it affect her Hope, it affects her billing too. And that comes from a space of billing. So You can look back at your HIS scores now and you can see where you need improvement. And the majority of the HIS questions aren't going away. And so if you need improvement for HIS, now's your opportunity to really, resonate with your clinicians about how important it is to make sure we're answering these questions to give us the best quality scores. And just like you mentioned before, this is going to impact, finances down the line. And so it's important that we do it right now, and it's important that, we're claiming all the time that we're spending with the patients, right? And so if you leave the patient's residence and do your documentation, you can't claim that time. And so I'll get off my soapbox there, but it all ties together. It all comes together. It's data that we're given to CMS, and they're going to use that data to reimburse us eventually.
Great. Amy, let's call for the soapbox.
I know, and I do have something. So, bringing it back to product design and really delightful product design. The intent of a beautiful note that leads a clinician down the path of clinical quality documentation, it really is intended to be designed to be used at the bedside, because if they're not documenting at the bedside, they're not getting those prompts that we have really worked to put in front of them, right? The design of bringing, using technology to help a clinician navigate a quality change is really fundamentally built on the thought that that clinician is using that tool while they're delivering care. And so it is fundamentally important that they understand that the documentation, if it's built in such a way that is really delightful, should be a tool that they can use that can support them in ensuring that they are dotting I's and crossing T's while also caring for their patient.
Yeah.
Wonderful. Wonderful. All right. Sorry, guys. It's what you get when the Geek Squad comes out. All right. Thank you both for sharing your expertise. We have a few minutes left, and I would like to ask you now, about 6 weeks. Can you believe it? 6 from Hope implementation. What do you recommend our participants do today to ensure success with Hope? Amy, you go first.
I really feel like we kind of just divulged into all of that. I would say the biggest thing is ensure that your clinicians are aware of the new Hope questions and ensure that they're documenting timely. And I would say continue to sweep out where there may be opportunities in your current processes that are going to be really extra exposed come October 1st, so that it feels a little less painful come 10/1, because you've already kind of gotten ahead of it.
Wonderful. And Karen, how about you?
I tell you, I would be printing off the Hope CMS manual with, all the guidance, and it would be our study book for the next month. And we would be going over every one of those questions, why they're important, why we need to answer them. I would explain, if, pain not rated doesn't mean that the patient didn't rate their pain. It means you didn't rate their pain. Right. And so they need to understand that, or, even teaching, staff, how do you assess, for 7, characteristics of pain, to prove that you've done a comprehensive assessment in a dementia patient, right? How do you capture that data? I would be educating on all of that.
Beautiful. Beautiful. Thank you, Amy and Karen, for sharing your expertise and wisdom today. By anticipating industry needs and collaborating closely with stakeholders, we are not only preparing for Hope, we are helping to lead the way forward. Please look for an email in the next few days with a link to today's recording and Axxess's Hope landing page with tools and resources to ensure your success in understanding Hope. This email will also include a link to training and certification provided by Axxess, where you can find an Introduction to Hope course. This course is 1 hour, 1 CEU, if you're in a state that needs CEUs, with 6 micro lessons, including case studies that Axxess is providing to anyone who wants to learn about Hope at no cost. And this is available to you today for your entire team through October 1st. This is a great way to train your entire staff quickly and efficiently. The email will also include the registration links for our upcoming Hope webinars. And hold on to your hats. Next week, we're going to talk about iKeys. So don't miss that one. Register today as soon as you get the link. Hope iKeys submission, the keys to success. No pun intended. Have a wonderful day. Thanks for joining us.
Thank you for joining Axxess On Demand. Visit axxess.com for more on-demand videos, industry resources, blogs, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.